Hi, everyone. We are super excited for this seminar with you guys. And we are really excited in general to work with the community of Down syndrome patients. We believe that we can benefit the community in both the skin diseases, as you'll hear today, but we believe that JAK inhibition in Down syndrome can actually work more than for the skin. We believe it's maybe potentially more than skin deep. And I'll introduce us first, and then we'll start a series of lectures. But first, I'm Emma Guttman. I'm from Mount Sinai. I'm the chair of the Department of Dermatology at the Icahn School of Medicine at Mount Sinai. And for a long time, I'm working on inflammatory skin conditions, particularly on atopic dermatitis or eczema and alopecia areata, but many other inflammatory conditions as well. And I was very intrigued by the fact that patients with Down syndrome have an overactivation of JAK1. My friend and partner in crime here, that you'll hear more from him, Dusan Bogunovic, maybe the world's best expert in Down syndrome and the abnormalities that patients with Down syndrome face. And he was trying actually to interest me to work on Down syndrome for quite some time. And we got together and also together with Benjamin Ungar, that is the director of the Alopecia Center at Sinai, and also did a lot of work on inflammatory skin diseases to put together a study or a clinical trial that we believe will benefit patients with Down syndrome, both if they have eczema and alopecia areata, but we believe it will benefit the entire well-being of patients with Down syndrome, because JAK1 activation is beyond skin deep. It also is important for the cardiovascular morbidity and many other morbidities that we see in Down syndrome. So we believe that this will be a very important study and an important treatment to benefit patients with Down syndrome. So we are very excited because, we want to do good by patients, and here we can help even beyond the skin. So sorry for that long introduction, but we are very excited about this study and benefiting these patients. And first, maybe we'll do a little bit introduction of the panel. Maybe we'll start with Dusan.
Sure. Hi, everyone. My name is Dusan Bogunovic, and I may know some of you because you're already enrolled in a research study that we are doing. We are extremely interested in better understanding the immune system in Down syndrome, understanding inflammation in Down syndrome, and that's really where my and Dr. Guttman's world merge together with Benji and Giselle, who are here, who are very experienced clinical trialists. And I'll show you in a second how this all came about. As what Emma was pointing out, yes, skin is when this can manifest, and this is where it manifests in typical population too, as inflammatory disorder. But in Down syndrome individuals, it's just extremely more prevalent. It's more frequent, and you well know if you have Down syndrome or if you're taking care of somebody who has Down syndrome, how often skin conditions are a problem. And perhaps more importantly, in most of the clinical trials, and I'd say actually all, where drugs who help tame skin inflammation have not included individuals with Down syndrome. And this is the only way we can truly know what is the right dose, as opposed to going to a doctor and changing something based on typical population. This will give us a clear direction of what works and how we can manage it better. So I'll say that here, and then I'll show you some slides in a bit.
And Giselle?
Hi, my name is Giselle Singer. I've been doing clinical trials for over 30 years. And one of my little jobs is to be the go-between between NIH, Mount Sinai, and getting the study approved so that we can enroll patients like you, relatives. We want to get the word out there. So if you have any questions, feel free to reach out to me as well as any other of our panelists.
Thank you. And Benji?
Hi, everyone. My name is Benjamin Ungar, Benji. I'm an assistant professor in the Department of Dermatology at Mount Sinai with a particular interest in inflammatory skin diseases. I'm the director of the Alopecia Center here, so particularly a focus of mine, a condition that particularly affects people with Down syndrome and atopic dermatitis or eczema as well. Very much looking forward to this effort, as well as give a little background for inflammatory skin diseases in people with Down syndrome.
Okay, so let's get started.
Okay, I think I'm next. I'll share a small presentation with you. Feel free to reach out to us throughout this webinar. We want it to be as interactive as it can be. If you're shy to ask questions, just shoot an email to me, to Emma, Giselle, or Benji. We'll happily answer any of the questions you may have. Okay, I think you can see in my slides well. So I'll talk about inflammation in individuals with Down syndrome. This is something that we started working on in 2019, where I became interested in understanding how does inflammation contribute to clinical outcomes, to how you feel, to how your skin is, to how you react to pathogens, how you react to infections. So that's really when it all started. As you know, that in the United States, 1 in 700 newborns has a diagnosis of Down syndrome, and there are congenital cardiac defects. There's problems with the gut. There's, of course, higher incidence of Alzheimer's disease. But in parallel to all of those, there are prominent immune features, and you'll hear about Benji in detail about this. But essentially, we and others know that there is a higher increase of risk of severe infections. We know that there is a higher rate of autoimmune disorders. We know that there is severe skin inflammation at 5 to 10 times higher rate than a typical population. And also there is much higher rate of alopecia, and which is a fancy word for hair loss. Okay. So we wanted to ask a very simple question, and that's how does trisomy 21, or how in individuals with Down syndrome, our immune system promotes this inflammatory setting? What is it? We need to define what is causing this inflammation for us to be able to therapeutically intervene. And today we're talking about this clinical trial, which is a drug that's hoped to tame this inflammation down. So here is what we did. We took and talked to you about being part of the research study, both through Mount Sinai Pediatrics or through Down Syndrome Connect database. And then we collected whole blood. Usually when you had your thyroid checked and there was a blood draw anyhow, we piggybacked on that with your consent and did a bunch of arrays just to try and understand what does this inflammation look like, right? I won't go into details of this. This doesn't matter. But if you look at this graph, what you can see is at the top, it's red, in the middle, it's yellow, and at the bottom, it's kind of bluish yellow, right? And what this means is that 1/3 of individuals with Down syndrome have very high inflammation levels, right? This is you, this is us, this is my best friend's child who has Down syndrome. It can be about 1/3 of the patients we tested have high inflammation levels. The other third is in the intermediate levels, and only 1/3 groups with typical individuals, suggesting that 2/3 of individuals with Down syndrome are inflamed. And we need to intervene there because the inflammation may result in many different clinical problems that can have. In this clinical trial, only those that have skin problems will, of course, be included because we have to be very precise as to what we are testing, even though, as Emma pointed out, we are hoping the benefit is greater than the skin. Okay. We've also tested this over a course of time, so 6 months apart, and we all again got the same group. About 1/3 of our patients with Down syndrome remained there. So inflammation is omnipresent. It doesn't go away. It's there every day, and the bodies have adjusted to deal with it. But we don't want that. We want everybody to be in this lower group with the typical population and some individuals with Down syndrome. We've looked at the immune system and looks largely normal. One marker of inflammation, if we now start to look inside the cell, is what we call here phosphostat 3. And when we looked at the immune cells, which would be the white blood cells in your blood, and we specifically look at this marker, we see that is high, right? So more of it means there is more inflammation, not just circulating, but inside the cell as well. And this is really the key experiment that we did in vitro. So from those of you who partook in our clinical trial, sorry, not in our clinical trial, in our research study, when we got the blood samples, we treated them with a JAK inhibitor. It's a little bit older class of JAK inhibitor. So if you think about it, it's like having a car from the 90s as opposed to having a car from 2024, where we have better engines and everything is better working. So this is an old car and it still worked. If you looked at these black dots going to red dots with this drug, which is the same class of drug that we'll be testing in this clinical trial, but a much better, much newer, better safety profile drug, this worked. This inflammation levels we were able to reduce. So the idea is that this elevated inflammation is influencing cells to be inflamed. And this is also influencing our rest of our immune system to kind of potentially attack ourselves. So the idea behind all of this is to use abrocitinib, which you'll hear more about today, which is the drug we are testing, clinical trial that NIH approved for us to do. We'll be able to block this inflammation to activate these cells. We'll be able to block this inflammation to communicate to other cells that can cause this self-attack. And we're hoping to be able to block this kind of circuit of inflammation that keeps going on in individuals with Down syndrome. And all of this should work very well on skin diseases, which is the primary inclusion criteria here. But as Emma pointed out, and as Benji will point out, immune system is everywhere. It's not just in our skin. It's in our brain, it's in our muscles, it's in our heart, it's in our gut. And some of these classes of drugs can work on multiple diseases, right? But because of regulatory things, we will be testing just this in skin, but we'll be monitoring everything else. So we hope we learn well beyond the skin how this class of drugs that should lower this inflammation can help you, can help your children, can help your friends who have Down syndrome. Louise Mal, she's an MD PhD student in my lab who did a bunch of this work, and she's absolutely phenomenal. But of course, I want to thank you, and I want to thank your families for being allies in medical research and medical advancement. A bunch of people in the lab, a bunch of our collaborators, and without whom none of this would be possible. So I'll stop here and hand it back over to Emma, actually going towards Benji.
Yeah, so we are very excited to have Benjamin Ungar give the next talk. And please do not hesitate to put any question in the chat, anything that is on your mind, nothing too little. So please, anything that is on your mind. But
Okay.
Benji, why don't you start?
All right, excellent. Let me see. Is this coming through my slides? Okay, excellent. So I'll be speaking more from the skin perspective in terms of Down syndrome. So, I think, we're all familiar with what Down syndrome is. It's quite common and it has impacts throughout the body. I mean, here's one schematic looking at all sorts of different components and effects that it can have in different organ systems and different parts of the body. But, as a dermatologist, much of my focus is on the skin, and there's a big component of affecting people with Down syndrome from the skin perspective. So taking a step back for a moment, people with Down syndrome have abnormalities in general, very commonly with the immune system. And that can be in two different sort of sides of the coin. On the one hand, people are more at risk for getting infections, but on the other hand, but on the other hand, there's also increase of autoimmune diseases and inflammatory conditions. And so I think it's helpful to take a step back for a moment and think about how can we, potentially evaluate the immune system to understand both when it's not working correctly in terms of fighting off infection and when it's overactive in terms of inflammation and causing diseases where it's overactive. And the skin, in many respects, is an excellent window into what's going on throughout the body because we're able to see the effects in skin. And very importantly, and this is something that I think we should keep in mind as I keep discussing, is that we have seen that for many, many people, inflammatory skin diseases are a reflection of systemic inflammation. So we see the effects in skin, but that's actually, again, a window into what's going on throughout the body. And when we think about treating people with skin issues, increasingly people, I think, are recognizing, understanding that we have to go beyond just seeing what effects we can kind of improve in the skin, but can we improve and affect and treat the entire person and the inflammation throughout the body? So broadly speaking, autoimmune inflammatory conditions are where the immune system mistakenly attacks healthy tissues. In the case of skin diseases, it attacks the skin in a variety of different ways. Their inflammatory skin conditions are quite common in the Down syndrome population. Anywhere from probably the low end, 1 in 4, but in some cases, some studies have upwards over 50% of adults with Down syndrome have reported skin issues. There's a whole long list of different conditions that can affect people with Down syndrome, and the two that I'm going to focus on, because that's both our area of focus with the study as well as additional research, are atopic dermatitis and alopecia areata. They're not the only two by any means, but I think that with the development of certain treatments that I'm going to touch on, we have a unique opportunity to hopefully improve these conditions in people with Down syndrome and also understand the effects of this inflammation both in skin and throughout the whole body. So what is atopic dermatitis? So it's commonly called eczema. That's sort of used semi-synonymously. And it's a chronic inflammatory skin condition with skin barrier dysfunction. Commonly, it's associated with dry, red, inflamed patches of skin. Itching is a major component that can lead to scratching, causing further irritation that also leads to additional breakdown in the skin, making it prone to infections. And this can kind of be a vicious cycle in many cases. Commonly appears, face, neck, elbows, knees, hands, but really can affect any part of the body. And in people with severe eczema can be covered head to toe with these inflamed lesions. In Down syndrome, the prevalence, ranges almost up to 30% in some studies, which is quite a bit more common than the general population, although it is common, kind of in the general population as well. And, why is it common in people with Down syndrome? I think that, we've kind of touched on this. There are altered issues with the immune system, skin sensitivity. People with Down syndrome tend to have drier skin to begin with, which can kind of feed into this cycle of inflammation, barrier dysfunction, and so on. And importantly, it's not just an aesthetic question. This can really impact quality of life by itching in and of itself is a problem. It can disrupt sleep, focus, daily activities, and so on. And so from the skin perspective, it's important to treat. And then, of course, from the whole systemic perspective, it's important that if we see that eczema is undertreated, then that probably is a reflection that systemic inflammation is undertreated. So, when it's relatively mild, atopic dermatitis or eczema can, be improved with moisturization, gentle soaps and lotions, avoiding harsh detergents and so on. But typically, that's not enough when it becomes a little more than that mild range. And then we have to use other kinds of treatments. So some include topical steroids or other anti-inflammatory creams. In some cases, antihistamines can be helpful with some itching, although typically that's more in terms of helping to sleep than the actual itch underlying the treatment. Light therapy can be helpful as well. But I think crucially, systemic medications may be necessary in severe cases or even moderate cases, particularly in individuals in a population where we know that there's increased systemic inflammation. And so those systemic medications historically have been broad immune lowering medications that have a ton of side effects, including significant increase for a risk of infections, again, in people who are already at increased risk for infection. And so I think that while it's crucial to treat people with eczema, atopic dermatitis, it's also crucial that we do our best to do it as safely and effectively as possible. So I'm going to shift gears now to discuss alopecia areata, which is another inflammatory skin disease that is common in the Down syndrome population. So what is it? So it's an autoimmune condition where the immune system attacks hair follicles, and that causes hair to fall out, and if untreated, very often prevents hair from regrowing. So commonly shows up, in small round patches on the scalp. However, very often that can progress to more significant involvement, or in some cases, it can present with rapid loss of hair throughout the scalp and even the whole body. This is a little less common than atopic dermatitis, but still quite common. And again, in some studies estimating almost 10% of people with Down syndrome are affected by alopecia areata. Also tends to occur a little earlier than the general population as well. And similar to eczema, there's this kind of issue with the immune system that's likely predisposing people with Down syndrome to developing alopecia areata and other inflammatory and autoimmune conditions. One of the goals, with this study is to understand better why that is happening in this population in particular, because it's outside the range of what we see in the general population. And, this can also have an impact on quality of life, mental health, stress, anxiety, and so on. So, similar to eczema, although not exactly the same approaches, the goal with treatment is to reduce the inflammation that is leading to the hair loss. In some cases, topical steroids or topical anti-inflammatories can be effective, but typically that's not a main part of treatment. If patches of hair loss are relatively small, we can do injections of steroids that are quite uncomfortable, painful, have to be done for a number of months, and often, is not really the kind of treatment we want to employ. And then very crucially, there's a new class of treatments, these JAK inhibitors that we've mentioned, that can be effective, and certain of them have been approved to treat alopecia areata. And then similarly, the kind of emotional support that you can imagine is necessary, hair loss, counseling, wigs in some cases. But of course, our goal is to treat the inflammation that's leading to the hair loss and that's affecting the rest of the body so that people can regrow hair and not be affected by the aspects that are causing distress. Okay, so JAK signaling, broadly speaking, plays a very important role in inflammation, fighting infection, and so on. And they, as we heard already, plays a crucial role in driving inflammatory conditions like alopecia areata and atopic dermatitis. And when that disease is more extensive, we really need a systemic treatment to be effective. There are 3 now approved JAK inhibitors to treat alopecia areata. As you can see here, depending on the specifics, either approved to treat adolescents or adults with kind of extensive hair loss. And for atopic dermatitis, there are 2 JAK inhibitors that are approved to treat. Now, I think one of the absolute crucial points and one of the reasons why this study we believe is so important is that although some of these medications have been approved to treat these conditions, they have not been studied specifically in people with Down syndrome. In fact, often people with Down syndrome are intentionally not included in the studies. And we understand that the biology, the immune system, the inflammation is unique in different populations. And so I think it's beyond important for us to understand in this population what the effects of these treatments are. We have reason to believe that there will be very beneficial effects, and we want to understand how and why that's the case. There are treatment challenges in Down syndrome based on screening and treatment inclusion in studies, often, referrals to dermatology in many cases, hopefully, not in New York City and Mount Sinai, but sometimes, referrals to dermatology can be delayed or kind of not occur. Treatment plans need to be personalized. Often regular follow-up is needed to monitor and change treatments. And one of the benefits of a clinical trial like that is that that's all built in, where everyone's very closely watched, monitored, evaluated, and really has excellent care and monitoring to make sure that everything is going well. The immune challenges, again, in Down syndrome make these challenges, treating them difficult because, again, we need to balance the improvement in inflammation while also reducing the risk for infections in people who are at increased risk. Now, the hope is that when we treat and improve the inflammatory kind of processes, that actually helps benefit the immune system in a way that will lead to this being a safe treatment in doing so. one of the issues, and again, this is, at the risk of repeating myself, is that there are often barriers to some of these newer effective treatments, even severe cases, because they're not studied in the population that hopefully would benefit from them. And that's again, it's so important that we are able to study, understand, and demonstrate the effectiveness in this population, so that way, we really can say with the degree of confidence, we're improving access to the medication, and say, hey, look, these really do work. Yeah, so the JAK signaling is increased in these conditions, and so therefore, I mean, you've heard this before. I'll say it again, that we believe that there may be broad benefits by reducing the chronic inflammation that is likely being driven, at least in part or potentially in large part, by the JAK signaling that we're going to be blocking. In mouse models, JAK1 inhibition, and the medication that we're talking about using here is a JAK1 inhibitor, improves the immune disorders. There are some cases of the use of tofacitinib as well, which is a JAK inhibitor that may help, treat alopecia areata and other conditions in people with Down syndrome. And there's some studies that have looked at that. However, tofacitinib is not approved for any skin conditions, and it's basically very, very difficult to get that approved. And because it's more broad acting and blocks more of the immune system, there are significantly increased safety concerns compared to the JAK inhibitor that we're talking about, abrocitinib, which is more narrow and focuses on specifically that JAK1 that we believe is playing such an important role. And so again, as I mentioned, the goal is not to just treat the conditions effectively, but also as safely as possible. And to do that, we want to be as targeted as we can while getting the improvement in effect. So these are some of the summaries and takeaways, and certainly we'll be happy to take questions as well.
So any question?
So actually, maybe I'll jump in because I do see one question. So my daughter, I'll just read it, as a new diagnosis of rosacea. And there may be a question of whether it's caused by a small bowel overgrowth. So rosacea is another skin disease that is common in patients with Down syndrome. It is considered to be inflammatory, and it is an inflammatory skin condition. The causes of rosacea, much like many of these conditions, is still a work in progress. There have been some studies that have linked gastrointestinal issues, including in some cases small bowel overgrowth, H. pylori infection, and so on, to rosacea. But I think the consensus is not really at a point where it's caused by small bowel overgrowth. That may be a link in a subset of people. And so, much like many of the other conditions we talked about, targeting the inflammation that is involved in a condition, I think, will be crucial. Unfortunately, we're not at a point yet, and the studies have not really shown that intervening from the kind of gastrointestinal side of things is effective in the condition.
Another question.
Take the one about the side effects of the JAK1 inhibitors. So we have now a lot of experience with JAK1 inhibitors, both the one that will be on the study, abrocitinib, and another one, upadacitinib, from another company, from AbbVie. And actually, both companies published more than 4 years data of safety. And I have to say, abrocitinib was studied only in skin diseases. Upadacitinib was also studied in arthritis, RA. They have many more indications. So, maybe the safety is a little bit different in the other indications, but so far we see very good safety of abrocitinib in atopic dermatitis. In this study, it will be given both for atopic dermatitis and alopecia areata. I want to also say that there are studies now with the JAK1 inhibitor from AbbVie, upadacitinib, for alopecia areata. And we also have patients that we treat for atopic dermatitis, but they also have alopecia areata and seem to grow hair quite rapidly, actually, on JAK1 inhibition, both on abrocitinib and upadacitinib. Overall, the safety seems good. We see some side effects that were suggested in the trials, like herpes zoster, more in patients over 65. We don't see them often in young patients. We do need to monitor blood. We need to do blood work. We monitor lipids, liver function tests. But so far in our department, we have many patients we treat with JAK inhibitors, whether for atopic dermatitis or alopecia areata. We have a good safety. Also, in the study that was done, that shows that the safety is slightly less good in over 65. Also, there are more infections and some additional issues in patients that smoke. So smoking is also a risk factor. But if you're not a smoker and not over 65, I would say the safety is good. And even in patients that are smokers and over 65, it's not that we don't give JAK inhibitors. We just need to be minded and really monitor it, which we'll do within the study. Anyone wants to add anything else, Benji?
Yeah, I don't really have too much to add. I think I'll just echo the idea that they tend to be very well tolerated, have demonstrated a very good safety, both in terms of our department and really just a lot of studies looking at, you know, the many thousands of people who are on these medications now for a number of years. And then on a day-to-day basis, typically they're not really associated with, you know, common side effects. You know, not just in terms of big side effects, but even relatively mild ones. You know, people can get like a little acne sometimes, and that's pretty uncommon. Maybe for a few days get a little stomach upset or headaches, but even when that occurs, which is uncommon, it tends to resolve, and people really don't necessarily feel on a day-to-day basis that they're taking a medication, except hopefully the beneficial effects in terms of their skin.
Definitely. And I see another question, who is not a candidate for a JAK1 inhibitor when you have Down syndrome, and how it is administered and monitored? So I don't think for this particular study that we are doing, we are seeking patients that will have enough disease, whether it's eczema or alopecia areata. But if you do, will not turn people away if you qualify in terms of the disease inclusion criteria. And the administration is oral, and the monitoring is via blood samples. We need to monitor, like I said, the things are good in terms of the blood, lipids, CBC needs to be done, LFTs, but we are happy to include all the people that qualify in the study.
Yeah, we'll be clear with that. Basically, if you or your child or somebody you take care of has eczema or alopecia areata, that's the inclusion criteria. And in terms of the safety, everything was mentioned. And also one important thing to mention here, that this is the new class of drug that has superior safety to any JAK inhibitors to date. So really, I think it's kind of beauty of the study to include individuals with Down syndrome after this has been studied for safety in typical individuals, but not for all indications. So it's really as fast as we can to include, so we can know what's the right dosing, because if you're high inflamed, your dosing might be different than if you're in low inflamed. And without doing this study, we just simply won't know, because if you give it, you know, what a typical individual gets, it might just not work. Whereas in this study, we've inbuilt the dose escalation, so those non-responders can become responders because we can, you know, double the dose of the drug, again, in a safe manner that's approved. So, yeah.
I love these comments. This is why we are so excited about this study, is because here we are taking a drug that is approved for eczema, but you need to have a 10% of the body surface area involved. In this study, you don't need to get 10%. You can have less involved. You still need to have it involved. And we are also opening it for patients with alopecia areata. And sometimes you may have one disease, may have both diseases. We know that's also possible. And this drug is much more targeted, right? It targets only JAK1. Other studies were with tofacitinib that is much more broad, targets JAK1, JAK2, JAK3, leading to many more safety concerns and has not been approved thus far in any dermatological indication. Whereas we are going for a drug, and was tried, by the way, in a dermatological indication and was not approved. So this is a much safer drug, right? We want a drug that is much, much safer for our patients with Down syndrome, that they can actually use it in the future and get it from their physician once we see and determine their dose. So the Mount Sinai location is the main campus at 98th Street. It's our main campus. And Giselle, can you take the travel?
Let me just read the question. So the visits are going to vary. They may be somewhere between every 2 months, maybe every 3 months. We're going to try to make it as infrequent as possible, but of course, you know, the NIH has to approve our design. And we do offer a standard fee of somewhere like $100 per visit to cover costs. However, in special instances, if you live far away, you need it costs you more to travel to us. We do have some flexibility with higher reimbursements.
And then I'll
So-
just add in, you know, that in terms of signing up, you know, get the information here, reach out if you're potentially interested or you think they may be candidates. And then as we finalize the study and begin enrollment, then, you know, we'll certainly reach out. I do also see a question of what do you mean by the statement safety of systemic agents in patients with Down syndrome is unclear. So, you know, I think I'll just start off and then maybe others will weigh in, but I think it's very important to understand that the context in which medications are given makes a very big difference. And what I mean by that is the same medication given to treat different diseases with people with different comorbidities, different other conditions can have a very big impact. And so if you have this medication given in a population that's at increased risk for infections and the medication's immune lowering, that may have a different safety profile than in a population or individuals that are not at increased risk for infections. And so the reason that, you know, the statement, it's the safety of these systemic agents is in patients with Down syndrome is unclear is because in order to answer that, it needs to be studied in a more formalized manner, and that hasn't been done yet. And so we have reason to believe for all the other people that have been treated that that it will be safe, and that's certainly our hypothesis and expectation and all that. But at the end of the day, for people who are, let's say, not participating in this study, they will only be able to look to kind of evidence and that's in people with Down syndrome who have been treated, and that's one of the goals of what we're trying to do here.
Yeah, Benji put it really well. I think we want to make a difference in Down syndrome patients and in eczema and alopecia areata in the context of Down syndrome with medications that we believe are the next generation, right? We know that there are studies with tofacitinib and there are case reports with tofacitinib. Tofacitinib, like I mentioned, is a medication that has not been approved while it was studied for skin indications due to safety. However, this new class of JAK inhibitor is now approved in skin indications, but we want to study the unique population of patients with Down syndrome and how they respond to these new drugs and understand really what is the dosing that is required. That's why we have both doses, 100 and 200 milligram, to really optimize the dose. And I think that will benefit the future treatment of skin diseases in the context of Down syndrome. We currently see very good safety in our other patients, not patients with Down syndrome. So we anticipate that probably the safety will be similar, perhaps even better in a way in patients with Down syndrome because they have that overactivation of JAK1, and we anticipate that maybe the effects will be even more beneficial, but that's why we need to do the study. And
So the question of psychological side effects with the use of this medication, None are reported apart from the headaches that Benji mentioned. And actually, there is an anecdotal upside. When JAK inhibitors were used in skin conditions, some of the patients with Down syndrome had the Down syndrome regression disorder, which is unfortunate event that happens in some individuals with Down syndrome where they go into psychosis and they're not who you remember them to be for those periods of time. And actually they had extremely positive reaction to this, that they didn't have an episode of psychosis while on JAK inhibitors. So while we are not studying that, and clinical trials have to be very precise, if anything, we think it can potentially benefit should any psychological effects already be present, as opposed to going the other way around.
I couldn't agree more. We still do not have experience with this drug in Down syndrome patients, but I can tell you, looking at targeting JAK1 in either patients with atopic dermatitis or alopecia areata that are treated with JAK1 inhibition, we actually see an amelioration of their psychological, because think about it, when you don't have hair, it affects you, right? So many times your well-being just by getting back the hair is of course improved, and the same happens with eczema. When you itch and have terrible eczema, it affects your entire life. So we usually see that when these are treated successfully, you improve your well-being, and we anticipate that to happen as well in the patients with Down syndrome.
There's a question that says, I've been told white blood cells is always low in Down syndrome, and that is no problem. You mentioned something about white blood cells. Can you repeat how low numbers influence this? So you're right. Some white blood cells numbers, like B cells, are always low in individuals with Down syndrome, and for the most part, that is okay. There is no problem in taking JAK inhibitors for those who have this condition, and that's everybody with Down syndrome. Whether this can help with white blood cell numbers in Down syndrome, we don't know. We'll monitor, and hopefully we can find that out.
So I can jump in for the next question regarding, are there any particular brands of topical lotions for outbreaks of mild or moderate eczema? So, I'll just say it's difficult to make broad sweeping statements because, we really try to treat the individual in front of us, and it's not just a platitude. There really are individual circumstances and considerations that vary from person to person. And even in someone with mild to moderate eczema, kind of an over-the-counter moisturizing lotion may not be ultimately the best or right treatment. To some extent with mild eczema and even with moderate eczema, frequent moisturizing, frankly, with whichever moisturizer is best tolerated and, that is going to be the easiest to apply consistently, I think is a good practice, but it's generally better to get, input from a dermatologist because there may be some specific considerations or, some prescription medications ultimately that would be more effective. And if we're already in that moderate eczema range, then it may actually be insufficient to treat with topicals in many cases. One of the reasons why this is an important study. So even if it's not in the very severe range, often systemic treatments may be actually, a more appropriate way to go. And the only way we're really going to be able to understand that is by seeing, an individual in front of us, assessing it and kind of understanding more about the treatments in this particular context.
Here's the next question saying another study with JAK inhibitors for skin conditions was monitoring cognition. Is this part of your study as well? All right, the study you're referring to is absolutely great. However, it is a tofacitinib, which is not approved for skin conditions. So even if it works, it won't be approved by FDA, which means you have to pay, you have to prescribe it off-label, to pay it out of the pocket, so it just won't work. With abrocitinib, the study we are doing is approved for skin conditions. We want to make sure we use it right in individuals with Down syndrome. We're hoping it might work to help with cognition. We are not particularly studying that because to study that well, and maybe that's our next study, to be quite frank, should this work well, you have to have a big cohort that you can compare to each other. And here our inclusion criteria is 12 plus. So it's a developing child and it's an adult. So we want to make sure that, how do I put this nicely? If it works, we have to test it in children so we can see this cognition. Whereas in developed adult, there can be improvements in condition, but then you have to adjust and you have to have right numbers. So we will pay attention, but it's not part of this particular study. There was another question, how is this drug administered? I don't know if
Yes.
it's answered.
Yeah, I
Orally.
Yes.
answered
Thank you.
orally, and also
Okay.
it's 60 weeks total, the study.
So
Mhm.
about a year.
It's about a year, and it's a drug that we will provide also to patients that don't have necessarily the severity that is needed when you have eczema. And this drug, let me also remind everybody, is not approved in alopecia areata at all. But we do see now in many reports and in practice that it has a great benefit in patients with alopecia areata and very fast benefit. Many of the approved drugs in alopecia areata take quite a long time to work. We see actually the JAK1 inhibition may actually work even faster. So there are many benefits here, and you will be monitored throughout by a super experienced team that, again, we want to make a difference in this disease. Any other question? Those were great questions, by the way.
If the person with Down syndrome cannot swallow pills, are there any other alternatives?
So I think a pill, my kids when they were little could not swallow anything. I was crushing all their medications in jam. I think it seems that you can find ways around it.
Yeah.
Sometimes you
much.
can't crush a pill, but we can definitely look into that option if this particular pill can be crushed.
There's a question in chat.
So I think I answered this. I have been told white blood cells is always low in Down syndrome. It's no problem. That's correct.
Mhm.
You mentioned something about blood cells. Can you repeat how low numbers influence this? You're correct. Their B cells are low in patients with Down syndrome. JAK inhibitors, I think, can help that. This is not the primary endpoint of this study. It's, of course, skin, but we will be looking into that. There's another question.
There is a question, if this helps once the medicine is stopped, would hair loss come back? That's an excellent question. So far, with anything that we give, it needs to be given all the time. But up to now, the studies for hair loss were done with people that had 50% of the scalp lost or more. Those were the populations we were looking into. Here we would look at the population that also has less hair loss, and it's unknown what happens in that population. In those that have more than 50% scalp, at some point they are likely to start losing hair. So that's why eventually we would like to transition people to be given drugs through the insurance, which after we identify the dose and people were for a while on these drugs, I see that this will be likely possible.
Yeah, typically, I'll just add, typically if there's a treatment where someone gets on for whatever reason, a trial and all that, it makes it much easier to go to the insurance and say, hey, you need to keep giving this medication because it's working.
Exactly. They will not be able to deny somebody that was on the drug for a while and we show benefit and we will give a letter of
that's the point here, because if we have a study, we publish this study, then it becomes a body of evidence that both regulators and insurance companies follow as practice, right? So that's how we are helping everyone, including ourselves.
Exactly. And again, we want here to help the community of Down syndrome patients. We feel that this will help their skin diseases, but not only. We feel that maybe this will help them in other ways as well. Somebody says here, Giselle says the pill in this study cannot be crushed.
Yeah, I just checked. Yeah.
Yeah, so maybe swallow it with some jam or, some creative ways.
Yeah.
Any other questions?
There is a concern for immune suppression or tolerance. What is the half-life of the drug? In other words, if there is any adverse effects or concerns, how long would it take for the drug to leave the system? This is a fantastic question.
Fantastic.
Yeah,
And actually,
I can answer that. It's
oh, go ahead.
in the range of about 12 hours. So
Yeah, it's
12
very
to
short.
14 hours, something like that. So basically, if there's reason to stop it within, 3-4 days, it's completely out of the system.
Yeah, and we've had a very, very difficult case, nothing to do with Down syndrome, on a patient who was on heavy-duty immunosuppression, and this was an add-on drug, and she did very well. And in 4 hours, we couldn't see any effect of the drug. So really, you're kind of pulsing the inflammation away, but not removing it, which we think is probably why the safety profile is relatively good for this drug.
So, and I'll just add, I think I actually may have misspoken, confusing with a different JAK inhibitor. I think it's the half-life's even shorter, a matter
Yeah.
of like
I think it's
6
like 3-4
hours.
hours.
Yeah,
Yeah,
exactly. So the short answer is but once you stop taking it, it's effectively out of the system very quickly.
What similarities are between the JAK1 you are planning to use and tofacitinib? So you can think about it as broad spectrum and narrow spectrum. So tofacitinib is much more broad spectrum, and we now know has some safety issues because too much of immune suppression. And the drug we are using is a narrow spectrum that is also supposed to relieve the inflammation, and therefore probably significantly safer, at least in typical population.
Yeah, I'll just add again briefly, abrocitinib is more specific for JAK1, so it's blocking the JAK that we want to. Tofacitinib blocks JAK1, JAK2, JAK3, and so is having effects on other JAKs that we're kind of quote unquote less interested in here, and therefore has effect not only to impact what JAK2 and JAK3 are doing, but also side effects that may arise. So we're getting kind of the benefit of what we're looking for without some of the kind of potential increased risk, side effects, and so on.
Absolutely. In fact, there were never studies head-to-head between tofacitinib and a JAK1 only inhibition, but I can tell you from what we've seen in alopecia areata, for example, the newer drugs that are more specific show better efficacy actually than the JAK, and it's probably
less is more. Yeah.
Less is more, and it's also a matter of dosing because it's safe. You can give higher doses. And here you are targeting exactly what's dysregulated, whereas in tofacitinib, you need to give much lower dose that probably is not sufficient.
Yeah. And Giselle answered, so we're hoping to start early in the new year. In part, we have writing the protocol. We want to make sure that you are heard. So if you have suggestions, if you have inconveniences, if you have fears about any of this, please write to us. It's very important for us to take into consideration how you feel, how your children feel, because that's, as a community, that's the best way to run any clinical trial. So with your feedback, we'll be submitting this and hoping to recruit first patients in early next year.
Yeah,
which is only a few months away, so it's soon.
Yeah, absolutely. We again, like Dusan mentioned, we like the idea of engaging the community here. We designed the study for you, and we want you guys as active participants in the study along the way.
A question, can a person with Down syndrome and an MTHFR mutation be a candidate for the JAK1 drug? We think yes, as long as the skin involvement is of that of eczema or alopecia, the answer is yes.
Yes, 100%.
Okay. Yes, absolutely. Do all participants receive the medication? Yes, absolutely. Every single participant. There is no placebo arm. We thought it wouldn't be fair. It's not a practice that we like. So we will have the comparison of day 0. So the first time you show up in clinic and we do blood work just like we would do for thyroid checkups that you go for. We'll compare that and your skin over the course of a year as you start taking drugs. So you'll be compared to yourself in a way at time zero and how much you improve. And yes, everybody gets the drug.
Yeah, that's the beauty of this study. Everybody
Absolutely, yeah.
benefits, and we all will learn together what is the best dose and the best practice for patients with Down syndrome and how to best support them when they have inflammatory skin diseases in general. But here we are talking particularly about eczema and alopecia areata. So we have a lot of experience in these diseases, but I don't think anyone worldwide has experience in these diseases, particularly in that population.
Right.
And we want to really understand what works best in this population, hone in this population. Any other question?
Yeah, we're coming up on an hour here, so
Yeah.
this is great. I love all your questions. Thank you so much.
Thank you for your engagement. Already I can see how this will be a great path for the entire community for better treatment for skin diseases and perhaps beyond. So with that, thank you for your attention. And you'll also be able to find this seminar online. We'll put it online at the Mount Sinai site, Columbia site, and in
clinical trials, Down syndrome clinicaltrials.com as well.
And most support groups will also have it.
Absolutely.
Excellent. Thank you so much. And it will be an exciting journey. And thank you for your partnership. Bye.
Thank you very much.
Thank you.
Bye, everyone.
Bye.
Bye-bye.